Okay, evening everybody. For tonight's Community Leadership Overview and Scrutiny Committee. Welcome to our esteemed guests, John Fox, Head of Health and Partnership, Councillor Gina Placey, Partnerships Portfolio Holder, and Damien Williams, just come back from his holiday in hospital. I'm glad to see you back, Damien. In actual fact, you are Corporate Director of Operations and Delivery, so I'm not quite sure where that fits in. Anyway, we won't go any further. And then also to our committee as well. Just to say that we will be moving item 5, which is the work programme. That will be coming on last now on the basis that some of the things which is brought up in our discussions can be added to the work programme. So it's just a subtle change. So item number 1 is apologies for absence and substitutions.
Thank you. Councillor Barrett, Vice Chairman of the committee, has given his apologies with no substitutions.
Thank you. Number 2 is minutes of, there's two meetings on the 14th and the 28th of January. Can I confirm and sign those as true records? Can we have a proposer and all those in favour? Thank you. And I'll sign my life away on those. No. I would remind members, declarations of interest, as and when. Item 4, questions on notice pursuant to Council Procedure Rule 38.
Thank you, Chairman. There are none.
Thank you. I'm going to move on to item number 6 on the agenda, which is the reference from the Crime and Disorder Task and Finish Group. I'd like to hand over to Councillor Doyle. Carrie.
Thank you, Chairman. Can I just draw your attention to the revised recommendations in front of you? The recommendations we will be looking at. The Task and Finish Group met 4 times to discuss the issues around familial violence, to gain an understanding of the complexities around domestic abuse, DA, and to see if there has been an increase or a decrease in reports of DA via comparison of data sets. I want to thank my fellow councillors on the Task and Finish Group for the dedication of time they gave to the group's work. This was especially the case in 2 of its meetings that I couldn't attend due to an injury I sustained and an injury my mum sustained. In respect of the work so far by the Task and Finish Group, we did not address the entire scope of the inquiry envisaged by full council in August 2024. There are well-founded reasons for this, and it should not distract from the work that was undertaken and the recommendations now before the committee. A key reason why the scope undertaken was narrowed is that data relating to familial violence other than domestic violence was not available to it. As such, the Task and Finish Group decided to focus on those areas of scope for which they had data for. As part of its work, the Task and Finish Group received presentations from external agencies outlining the work they carry out to support survivors of domestic abuse within the tendering district. This was very impactful for the members of the Task and Finish Group, and the value of their work cannot be overstated. The committee will note that the data within the report was received from Essex Police and shows the recorded incidents of domestic abuse. When the committee members review that data, it should be noted that DA is an underreported crime, and in some cases, a person may be a victim of abuse for up to 40 times before they seek help from support services. Where someone bravely speaks out against the abuse they are receiving, they often become further isolated as wider family and social circles fracture, and often ongoing childcare arrangements can become a way that abusers can try to continue to inflict pain on their victims. The recommendations from the Task and Finish Group are set out in the papers for this committee meeting. However, upon reflection, the wording of the recommendations in the report could be improved, and I've taken the opportunity to review these, and I thank my fellow committee members for their assistance in this. I've set out on the table some revised wording, which when I move adoption of the recommendations, it shall be those set out on the table. It is timely to consider this report from the Task and Finish Group, in view of the fact that only last week the Council's Cabinet has approved the Crime and Disorder Reduction Strategy for submission to Council on the 20th of May. The report to Cabinet identifies that between October 2023 and September 2024, there was an 8.1% rise in reports of domestic abuse across Tendring. The strategy proposes that 1 of 4 community safety priorities for 2025 is high harm violence, with a focus on violence against women and girls and domestic abuse. The Task and Finish Group has identified some practical steps to contribute to the intended Community Safety Partnership priority referenced. Returning to the approved scope for the inquiry, it was intended that we highlight any gaps in provision that may exist, where we could work with partners in finding ways to support the residents of Tendring who are currently experiencing familial violence. Unfortunately, as mentioned earlier, data relating to familial violence was not available. However, the group did learn about the different types of domestic abuse, including coercive control, a pattern of intimidation, degradation, isolation, and control with the use of threat of physical or sexual violence, psychological and/or emotional abuse, physical or sexual abuse, financial or economic abuse, harassment and stalking, online or digital abuse, so-called honour-based violence, forced marriage. A further element of the approved scope was what will improve residents' experience when seeking support from TDC regarding familial violence. This may be improved by improved pathways of communication and safeguarding. Although every situation is unique, there are common factors that link the experience of an abusive relationship. Acknowledging these factors is an important step in preventing and stopping the abuse. The impact of domestic abuse can have massive influence on the wider family and friends of the survivor. Turning back to the inquiry scope, it anticipated it would highlight areas of excellent work currently being undertaken by staff at TDC in partnership with other agencies. Tendring Council are adopting their crime and disorder strategy for the next 3 years, and I have already referenced that domestic abuse is one of the priorities highlighted in the strategy. This is not a new area of work for Tendring CSP, who also have a priority to tackle DA and raise awareness of how to report DA to police or how to get support from specialists such as Next Chapter. The CSP partners work together to ensure that survivors in Tendring are offered support, and they work closely with Southend, Essex and Thurrock Domestic Abuse Board. Through our officers, the Council continues to support all domestic abuse campaigns and are actively involved in Domestic Abuse Awareness Week in November each year, and the annual 16 days of activism against gender-based violence. I am commending the report before you for adoption by the committee and submission of the recommendations circulated this evening. Domestic violence is a scourge of our society. Whether it is a man-on-woman violence woman on man, woman on woman, or man on man. We must call it out and support those who have been subjected to it. This task and finish group has provided an opportunity to look closely at this matter, and the outcome has identified the steps set out which can build on the existing work in this area. Our message to all concerned must be that if you are subject to domestic abuse, we are there for you, and we want public authorities, voluntary organisations and the community to collectively provide the advice, help and support you need. And to our young people, we must work to challenge toxic cultures that suggest that violence against a partner is somehow acceptable. It is not, and the resource referenced in the report can offer positive relationships cultures for them to grow. I will leave it there and propose adoption of the recommendations before you. I would like to move the recommendations as revised.
I think that's quite a hard-hitting statement, and also the actual report is. And I think, as Councillor Dorcarry has highlighted, that as a council, and I know Leanne Thornton has been involved as well, and she's at the coalface, if you like, have done really a lot of good work to make people aware that there is help out there. And I know one of the concerns of the committee was, how do we reinforce that information so to make people aware that there is help available? And I think that's a really good, hard-hitting statement to put forward tonight.
Can I just thank the officers for the work that they've done, because they've been amazing, to be fair, been really supportive.
Yeah, well, it's been a really good team effort to get this far. And Councillor Oxford.
Yeah, I'd like to reiterate that. I think it's an excellent report, and it's putting out there that we are here to help, and I think that is top priority. And I thank Carrie for that. Thank you.
Is there any other questions or comments from members? Or, sorry, Anne, did you want to come back? Sorry, did you want to come back? No. Damien, did you want to come in? I know you're sort of...
I think only to say that it was a really, really interesting task and finish group, and that it is such a broad topic, and it's fascinating to talk to outside bodies and understand the way in which our staff operate with them, to try to inform people, to try to support people. So for me, I think it's a really excellent piece of work, and I congratulate Councillor Doyle on her delivery.
Yeah. Okay, do you want to formally recommend? Or?
Yeah, so I
formally recommend?
Recommendations.
And a seconder? Councillor Davidson.
Thank you.
All those in favour? Thank you. Well done. Well done. Unanimous. As I say, a really good piece of work there, and hopefully all the task and finish groups will come on in the same vein. We're now on to the report of the Assistant Director, Health and Wellbeing Strategy. Mr. Fox. Oh, Ginny, sorry, Ginny, do you want to set the scene?
Yeah, I can say a few words. A little introduction, actually, because John has got a really nice presentation. I just wanted to reiterate the vision for this is quite simply to support residents to live healthier, fulfilled lives for longer. And also to add that it is still draft. It is out for an 8-week consultation. So hopefully we'll get some comments from you tonight, as well as from the wider public, that we could add into the strategy. So over to you, John.
Thank you.
Thank you. And I'll just get the presentation up. Okay.
watching, Chairman, this will be put on the website as well.
Yep.
Okay. So I'm here to present about the draft health and wellbeing strategy. If I move to the next slide. Okay. So this is what I'm going to talk about. It lists you what we're going through, but actually this is what's in the strategy itself. So we've particularly pulled out why we need a strategy in the first place, about the population health within tendering, something about the health index as well, because that's very significant for us, and I'll come on to this a bit later, particularly for those other areas around us as well, what our vision is and the importance of partnership working and our priorities. This slide, to some degree, encapsulates the whole of the strategy in one slide. So the strategy is highlighting how the council can work with its partners to deliver a preventative and wide determinants approach based on data. That is fundamentally what we're trying to achieve with the strategy. So just going through that, it's critically important that we work with our partners to deliver this, because actually we're all seeking to achieve the same thing. So you're probably aware of the North East Essex Health and Wellbeing Alliance. That's a group of partners coming together who are trying to address issues around health and well-being more generally, and all of those partners who might have an interest in that. And the council is one of those partners. And if I give you an example, if someone's going into hospital because they've got respiratory difficulties, that matters to the hospital, obviously, because that's a cost to them. It matters to the individual because they're not very well, and it probably matters to us because it could be something like their housing that's caused it. So actually, we need to align with each other to make sure we're all trying to achieve the same thing, rather than working separately. Us doing our housing thing, the hospital, for example, doing a let's make them better thing. It's about how we work together to make sure we can do this most effectively. The second point is about preventative. So prevention and early intervention is absolutely crucial as well, and that is right through the centre of the strategy. I was at an event recently, and somebody talked about a quote from Desmond Tutu, which sums up to me, which is, we've got to stop pulling people out of the river. Rather than pulling people out of the river, we've got to stop them falling in the first place. That is absolutely what the preventative approach is around. So we need to make sure we're doing something now to stop our population getting ill in future, or those whose health isn't so good, how we can support them to have the best lives they can. And wider determinants, if I can just talk through that for a second, that's sometimes called the causes of the causes. So often people think, what causes people to be ill? Well, is it because you're smoking, or you're drinking, or you've got bad diet, or you're not doing enough exercise? Actually, what the causes of that are, and these are these wider determinants, are the social situations which people experience. So that's something about what is your opportunity around the housing you're living in. So if your housing is really poor, that's going to significantly affect your life choices. Or the fact that you don't have many skills, or you can't get a job, or you can't access reasonable transport. They're the things that then lead on to people making poor lifestyle choices, which then results in illness. And then finally, absolutely about data. This must be driven by data, so we need to work out where those areas are in our area where we need to put the most effort. There needs to be a broad approach, so we're trying to impact the whole district, but we're trying to focus our impact on those areas which would have the most deprivation. A little bit here about why we need a strategy, which you're probably pretty much all aware of. So a couple of key features. So we've got increasing numbers of people living with long-term conditions, making their lives more difficult, and as it says there, some of which are preventable. So what can we do to do that prevention now to stop that happening in future? Tendering is in the bottom of the 10% most deprived lower tier local authorities, and the only one in Essex to be in that position. And as I put in there, that will result in worse health inequality, leading to worse social determinants such as poor housing or employment opportunity, and subsequently the worst health outcomes, and we need to be addressing those so we can make an impact on those health outcomes. And clearly as well, we've got a really significant issue about our population and the age of our population, because it is ageing. We have the highest rate in Essex, which is significantly higher than the England average as well. So there's a couple of key reasons why we do need to do something with our strategy. I did mention about the health index, and I think this is worth talking through. So we are facing a lot of challenges, but our health index is actually improving. That is a score which the Office of National Statistics have come up with to try and assess changes in health of an area over time. It was based on a 2015 starting point with 100, the score of 100 being the average for England. As you can see by that little graph on the right there, actually we started off in 2015 at 88. That means we were significantly worse than England, but there has actually been an improvement occurring since then. Actually, interestingly, Colchester, in the latest one, they had some real issues with getting worse, significantly worse, where we've improved. So we are bucking the trend in terms of what we're doing around health and well-being in this area. You may be aware already of when the Chief Medical Officer came, he referred to this and particularly said there is no silver bullet which will solve health inequalities for you. It's about how you put lots of interventions in place, and that's what will result in something like this, making these improvements. In terms of the health index, it's split into domains, which you probably can't see from there, but on the bottom it's healthy people, healthy lives and healthy places, and listed there are the improvement or improving areas that we've got in our area. Got something else about population health as well. This first one is significant. So this is the healthy life expectancy. So we are for men just under 62 and for women 63. Healthy life expectancy is how long someone would expect to live in good health, and it's done by their own perception of whether they're in good or very good health. So what age do they get to when actually that no longer exists? And actually 61 is a pretty low age when your healthy life expectancy, you wouldn't expect to have a healthy life expectancy. As I say, we are lower than Essex. Our partners in the Alliance, that is one of the key targets they're trying to influence, to increase healthy life expectancy, which feeds right back to that preventative approach. And so similarly is repeated through our strategy as well. That's important to us that we can influence healthy life expectancy because it's an early intervention and prevention approach. I've also listed in there about suicide as well, which is in our strategy, and it's one of the focuses we have. Tendring, unfortunately, has a very poor history around suicide. We are one of the highest areas there is in the lower tier authorities, and we have gone up again relatively recently. So that's a real key area of focus for us, as it is for our Alliance partners. And the Integrated Care Board, which oversees it all, over Suffolk and North East Essex, that is one of their key targets as well, because it's so significant. And finally, around overweight and obesity, although we've got some reductions in Year 6 children, the rates in reception age are currently going up. So we need to put some focus on that as well. That is the vision of the strategy. So pretty short: support residents to live healthier, fulfilled and independent lives for longer. And I think you can see in there very much that prevention type approach we're trying to take, an early intervention approach in terms of trying to help residents to live healthier lives for longer. We talked about partnership working, which I think is really significant. There is a number of examples I could have alluded to, and I'll just talk through a couple here. So you must all be aware of Essex Pedal Power, so that's the orange bikes, which have been, we did some work with Active Essex, and there's some money from the South East Local Enterprise Partnership helped start this off. Also some support from Sport England to try and do something about initially this was about making people more active, so that's one of the key areas we want to focus on. But when those bikes were given out, that wasn't simply just to say, can we make you more active? It was absolutely about trying to say to people, that gives you an opportunity to be active. We'll run some led rides together so you can come together, so you're starting to address things like social isolation and loneliness. It also gives the opportunity to start cycling to, for example, work, where you might not be able to get work previously because you didn't have the transport costs, or even to get to shops where you can get cheaper food or cheaper goods. So absolutely, our interventions need to be much more than just a single approach about, oh, we might make you more active. It's all the other benefits that come with that as well. We've also got an outdoor gym recently been put in at the end of last year on Holland seafront, about particularly trying to help older people become more active. And it's set up specifically for older people, but can be used by younger people as well, to try and help them prevent suffering things like falls and fractures. Sailship is another organisation we've also been working with, who are working to try and help adults support or get support around mental health. And they're working really closely with Open Road as well. So it's a sort of nature-based or garden-type-based intervention, where they're trying to bring people to somewhere where there's some peace and they can do some creative work to help build their strength and resilience. And then finally, I've put there about wellbeing hubs in schools. So currently, we're supporting or have been received funding from our health partners to support 33 primary schools around mental health and supporting young people to improve their mental health and build resilience. Just in terms of those priorities, if I go through those, and these are key to a document. So wider determinants of health, as I mentioned earlier, we absolutely need to have a focus around things like housing, social isolation and loneliness, skills and employment, and physical activity, because they're going to make a difference to our residents' health. Within the strategy itself, we have a priority, and then we have some actions underneath it we're hoping to achieve, and that's in your pack. You want to see those that delivery plan. Secondly, about improving well-being and resilience. So particularly that's a focus around mental health and how we support people improving their mental health, because we've got very significant issues in this district around mental health, as there are in many areas. How we encourage around a healthier lifestyle. That's about helping to improve physical activity, about how we do something about diet, supporting people with diet, working with our county colleagues. They have a healthy weight strategy, how we can support them to deliver that. Long-term condition prevention and management. Again, how we try and support people so they don't get those conditions in the first place, or support them that once they've got that, how they can live the best existence they can. And then finally, suicide prevention, and how we can work with partners to try and address some of those issues. That's really difficult because there is no one thing you can point to and say, if we solve that, that would solve the issues of suicide. It is an absolute multitude of factors that result in suicides occurring. To give you a bit of an idea of the timeline, so we're out to consultation at the moment. The consultation is an 8-week consultation until June, beginning of June. We'll then evaluate that in June and July and hopefully come back for formal adoption, hopefully in July or possibly August. As part of our consultation, we want to try and get a bit of a focus around some key questions. So when we go out to partners, these are the questions we're asking. They can feed back whatever they would like to feed back, but actually we want to make sure we've covered off some key points. So in there, those questions are: do you feel the strategy identifies the issues for tendering residents? Secondly, do you think the priorities will help address those issues? In terms of organisations, when we're going to them, because we will be going to lots of organisations, how well those priorities link with your organisation? Something about, is there anything else you'd like to see added? And just any further additional comments. Thank you. That's the end of the presentation.
Thanks, John. Yeah, that's again a really powerful presentation, a lot of information there. So thanks very much for that, Councillor Chris.
John, it's a very good presentation. I think, though, the elephant in the room, and the thing that I find really missing there, is where we stand within our planning. Because whilst it's all very well to have all these different priorities, if within our planning process we're grouping large numbers of HMOs around town centres in close proximity to each other, what we're actually doing is exacerbating the problem. We're putting people with similar social, economic and problems all close to each other. For example, if you've got a drug issue or an alcohol issue and you're living next or in close proximity to other people with drug and alcohol issues, you're probably sitting outside McDonald's in the town centre. And one of the issues with all of this is surely that unless we really take a proactive approach to our planning, so that we look at where we're putting people, how we're putting them, when planning applications are coming up, the number of HMOs that are in close proximity to where we're allowing additional planning to existing HMOs, we're really not going to sort of go somewhere to solving the problem. Because my view is that if you look at, for example, areas like Brooklands and Grasslands in Jaywick, where we've put significant amounts of money in to help people there, one of the issues there is a number of people that are actually on housing benefit that we're actually placing in these places initially. Now, surely, if we're serious about this, one, we need to look at planning and have a proactive approach to planning, so we limit the number of HMOs that are put in streets, so they're not one next to each other. Two, we need to look at where we've got large numbers of people that we're housing and see what impact our actual policies are having via planning on these factors. I mean, I know that one of the things that we're mentioning again in this strategy is the number of people over a sort of 65, where we're quoting 30% compared to the national average. But one of the things that ought to be mentioned here is a lot of those people in that 30% are coming here by choice. They're moving from outside the area, sometimes London. They're coming down here to retire. Now, this isn't a negative thing. This is a positive thing. This is because people want to come here, want to retire here, like the area, like the people, dare I say, even like the shops, and want to spend their time here. And I think that that's not a negative thing, that's a positive thing. And unfortunately, as one gets a little bit older, as I'm starting to find out, the health isn't as good as maybe when we're 20 or 30, and there are a little bit of issues that start to crop in that maybe you need to see the doctor for. Which doesn't mean that, just because you're 61 or 62, it's time to start looking at funeral plots. It means that sometimes you get a few aches or pains that maybe the local seaside gym on the front won't help, but a little bit of exercise then might do. So I do think when we're looking at this, that just because you're over the retirement age, that's not negative. In fact, in many ways, that's positive because people are coming here because they want to be here.
Thank you. I'll respond to both of those. That's a really good point about planning and HMOs. So one thing I didn't go into any particular detail, within the strategy itself, it does talk about the importance of how we align internally as a council as well. It's not just an independent strategy produced by the team I'm in, which doesn't have anything to do with anybody else. And in there we do raise a couple of particular departments we want to work with. One of those absolutely is planning. There's a meeting happening early in May where we're trying to bring those departments together to talk through this strategy and say, have we got this right? How more can you contribute to this? We don't talk about HMOs currently in the strategy. When we have this meeting in May, I will be talking to Gary Guyver, I think he will attend, particularly about that, about how could we do something. Is there the potential to do something around that? Because I don't know how planning works. So if Gary turned around and said, no, actually we've only got, if we refuse permission actually that'll be overturned. That could be difficult, but more than happy to have that conversation to say, is that something we need to get in here as well? Because you're absolutely right. I think when I talk about housing, which we do mention, actually quite often HMOs are quite a low quality of housing. They're a cheap quality of housing, and that's where people who are suffering the most deprivation probably end up. So there is something about, can we do anything around that? And I'll absolutely raise that in that meeting. See if we can get that into a strategy. And your second point about over 65s, absolutely, that is not a negative thing that there's over 65s in our area. It wasn't written to be negative, and it's interesting. I need to read it again just to make sure we're not having that effect. Because you're absolutely right, it is good to have them here and we want to support our whole population. But there's something about those who are over 65, when I go back to that healthy life expectancy, actually it's a lower age than that. How do we make sure we give them suitable support and provide them with hopefully prevention type things? And if it's not prevention because they already come with some condition or someone's lived here all their life and they have a condition, is there anything we can do to support them and help them? One of the things in the delivery plan is around, we're trying to do something around Singing for Lung Health, which is where we're trying to work with some community choirs to help them to support people who've got COPD, which doesn't have to be in over 65s, but might be a more prevalent in an older generation, to get their breathing better. So we're trying to support their respiratory system better. So something about how do we help people beforehand, but actually because we've got lots of people who might have poorer health, how do we support them as well, is what we're trying to do with strategy.
Well done. It's a really good discussion there, because obviously Chris, you brought some good points there, and John has taken it on board and actually going to set the process in. So I think that's a really good piece of discussion.
John. John, you identified in your presentation about well-being, poor health being directly to do with poor housing. What are we doing about private landlords that people are living in actual squalor? And obviously, it's not a real good a well-being for them, is it, to live in squalor? I've got people living eight people in a two-bedroom house. You did identify that in your presentation, and I wonder how we can, or how anyone can get to grips with these landlords that are letting place it to people that can't get on a ladder, obviously, and they are living in squalor, and obviously they're becoming quite ill, some of them. Is there anything we can do to regulate these bad landlords?
So the answer is yes, but that would be done through our housing teams, which currently exist. And I think if you have particular examples, it would be worthwhile contacting our housing team to get them out there to talk to them, because actually we should be addressing that. Yeah, the whole approach of the health and wellbeing strategy, which is to try and support people and prevent ill health. Actually, if we're not dealing with things like poor housing, that is something we need to address if we know about it. There is something about making sure people get that message through or complain, so they can be visited by a housing officer.
Yeah, I understand that, but the only way you can get an officer to go into one of these poor houses is for the tenant to ask for them to go in. I can't phone the housing on their behalf. Now, I will go to the tenant and say, look, you need to phone the council and get an officer in here. You need help. And what their answer is, if I phone them, I'll be evicted and I'll have nowhere to live.
Yes, I accept that. I think that is difficult, actually, because if someone is not willing to make a complaint, how do we get to hear about it? There does need to be a process. Think about our housing staff, they don't know what they don't know. I suppose all I can say is, I'd reiterate, it's about trying to help make those tenants, give them some support to try and to contact our housing teams, because otherwise we can't do anything about it.
Sorry, can I come back just once more? Yeah, I understand that completely, but it doesn't help them people who are getting iller and iller. And we're talking about health and well-being. So, something drastically needs to be done. Not only here, I'm talking about nationwide. Because it's not a local issue, it's nationwide. But I know we can't do nothing nation, but we need, something needs to be done to help people, bringing them back to good health, if you like, if you want to put it that way.
I don't. What I thought I would have is that, and certainly working in a partnership-based approach, chances are there'll be other agencies going in to see those individuals as well. And so if someone had an illness, for example, presumably social care might be going in, or a community nurse might be going in, and actually relatively recently a new referral system called Frontline has been set up over the last sort of 4 or 5 months, which gives the opportunity for agencies to refer through to something like the housing team. I don't think I'm really giving you an answer to say this is a solution, but it's a really difficult one to deal with if a tenant is absolutely adamant that they don't want something to go through to the enforcement agency.
Okay, now I've got Damien, did you want to comment specifically on this?
Yeah. Crikey, that was loud, wasn't it? I was just going to say, just to sort of reiterate what John's saying, it is a very complex situation, and we don't have power of entry if the tenant doesn't complain directly to us. Successive governments have been talking for some time about bringing decent home standards into the private rented sector. That hasn't occurred yet. And actually, my view is if you start to bring those standards in, then landlords can be more held to account. So there is something called the HHSRS, which is in relation to healthy homes. So an environmental health officer will go around when they get in there, and they can have a measure, if you like, of the state of the home and whether it meets healthy home conditions or not. But as it stands at the moment, the private rented sector team within environmental health, which is one of my teams, would require the tenant to come to us to say, listen, I'm having these issues. Now, I hear what you say, Councillor, but we can't do any more than wait for them to come to us. And it's often very complex, and some of the things that John touched upon before in and around deprivation and other things will lead to those pressures being put on families and individuals. But as it stands at the moment, my view is that when government bring in standards that private rented sector can be held to account to, that's the point where you may have a greater chance of trying to address those issues.
Basically, John, I would like somewhere along the line in this draft regarding youth clubs. I know we've talked at length about this. Very big youth club in Walton, over 300 at the moment on the books, running 4 sessions a week, fitness, hubs, youth club on a Tuesday night, young people any age from 7 right the way through to 15. We've had several youngsters that we've got back to school through the youth club. We've dealt with a lot of in-house issues. We've had self-harmers, we've had suicides, and we have dealt with it. Our biggest problem is getting volunteers to help, as you well know. But I do feel that TDC hasn't come to us and seen what we do. Apart from one, we did have the leader of the council did come down. We are self-funded. We are under Essex Youth Service. We have a group of young people at the moment down in Wales, down at Slade, under the Essex Boys and Girls Club. And I think we would all learn, well, I've learned, but we would all learn from going into a youth club and just seeing what we actually do on a Tuesday night. Thank you for that.
And certainly very happy to give some consideration to putting something into a strategy, because we haven't particularly referenced youth clubs at all. You then talked about things which are absolutely referenced in there. So skills, children go back to school, that is absolutely critical. That is. How you're addressing or helping to prevent suicide, that absolutely aligns with what the strategy is talking about. So very happy to have a look. All right.
Just come back quickly on that. The idea, yeah, youth clubs are a great hub. A lot of people just want to come, youngsters want to come down and sit and chat and offload. So they're quite happy to offload to us, not necessarily their brother or their sister or their parent. So we are able to pick up a lot. And at the moment, and I will mention Kevin Smith, who is my ambassador, who has actually taken over from me, although I'm there every Tuesday. It would be good to touch base with him, to have him down, to actually offload to you all and say, you know, what happens. Thank you, John.
Task and finish on after school activities. So I think maybe we'll make reference to him, and maybe you can get it into his task and finish, and then not only hopefully John will come back, he might come down as well with the task and finish group and give a bit more clout to it. Okay, that's good. Thanks. I know I've put a question in about the opportunity to explore joint working across North East Essex with Colchester and Braintree. If because the unitary is on the horizon, and I know you've made comments back, Councillor Paley, but is there going to be a convergence of strategy and policies? I understand that Colchester and Tendring are together as such, but Braintree is separate on the alliance.
I think I'm right in saying that Braintree comes under Mid-Essex.
Yeah.
And that's where the Alliance and other health people are looking at, do the borders change in the health partnerships? Because this is going to be a difficult one if we do end up as partners with Braintree and Colchester. I mean, obviously Colchester is already in North East Essex Alliance, but if we join with Braintree as well, do we have two separate bits?
Because that's going to become
it's an
more
unanswered question at
isn't
the
it?
moment.
That is going to become more and more important.
But I mean, the Essex Health and Wellbeing Board, the overarching aims there are what we're aligned to as well. So hopefully
you do have that.
it would be a smooth, hopefully it would be a smoother running. Demographics are different, and take what Chris said, we've got a lot more older people here, so there's all those things have to be worked out. And I agree with you, Chris, the older you get, the more aches you get and the longer it takes to get over them, so we need to keep active.
So on that question, we will write into the minutes that the question has been asked, and also your reply as well, which will be available to everybody on the website, and obviously the supplementary, which I've asked as well. So that's good for that. Councillor Griffith.
Looking at this, I think there needs to be an overarching view, especially when you're looking at health provision. I mean, one of the things that I'm aware of is that, for example, if you're in Colchester and you need to get to, say, the Ipswich Hospital, you're only literally a relatively easy drive down the A12 and across the bridge to get to the main Ipswich Hospital, whereas if you were going somewhere like Braintree, I've got to be honest, I don't actually know where the hospital is in Braintree, I imagine that is going to be significantly more difficult. And I think one of the things that might be worth considering, especially for those people that live somewhere near the Suffolk border, is that the health provision now with a tie-up between Colchester and Ipswich works quite well, because geographically they're quite near each other. And my concern would be that, especially when you look at, for example, the older population in Clacton, where you've got some excellent scanning units at Clacton Hospital, you're a relatively easy drive to Colchester, and it's not too difficult to get to Ipswich. I would be a little bit concerned if I had to try to get to Braintree, because that is quite a drive. And to be honest, the road network probably isn't the best, depending on what time you go.
Yeah, thanks. Councillor Doyle. Okay.
If I can, it's a really good point. I think actually the hospital in Braintree would be Chelmsford. That would be their nearest hospital. I think there's something around, and this is absolutely not worked out as far as I understand, just in terms of when you were talking about what is the, what will an ICB footprint be, what will a hospital footprint be, and what will the Alliance footprint be. I think that's still being worked out through the process right now, so it's not clear. But you're right, actually, critically as part of that, we need to make sure we keep arguing in this area to say, actually, we need access for our residents to be able to get to the services they need. I think the hospital, so Ipswich and Colchester, I do think service actually very well. There's the diagnostic hub, so they've put a lot of investment in this area to try and make sure there's a reduction in travel times for people, or easier services to access, and there's good service provision in those two hospitals. As yet, I don't know what it's going to look like if they reorganise what an integrated care board would look like. So at the moment, we're in the one with Suffolk and North East Essex, but there is a Mid and South Essex one, and there's also a West Essex and Hertfordshire one. That's a lot of complexity, which I think will, in to some part, be resolved going forward.
Actually, I've got another question pertaining to that. Sorry. Can we just be mindful going forward that when devolution occurs, that the ICBs will probably align to whatever we align to. However, we've already got an issue where some elderly residents in my ward, their partners end up going over to Basildon, which is the cardiac unit, which then itself has lots of problems because their partner's elderly, they can't get over there to visit. You know, there's all of those sort of social issues that support people's health and well-being. It's all well and good whisking your husband over to Basildon, which is miles away, but trying to get there on public transport is quite, especially as the government keeps saying we're talking about care closer to home. You know, that's not care closer to home, that's care miles and miles away, and it's just going to get worse. And I can see that happening. I can see them saying, you know, Ipswich will be orthopaedics, Colchester will be eyes and God knows what else, and they will designate specific specialities to hospitals. And I think we need just to be mindful that we have a voice in those proposals. But that wasn't my original question.
And just to respond to that, because you are absolutely right, Basildon is the cardiac centre. That's why people get sent there, and I think that's a fair point. Actually, it is very, very difficult for people to visit. Actually, Colchester is the orthopaedic centre now, which is a Europe-leading orthopaedic centre, which has recently been opened. So what we lose on one side, we gain on another. But it's a really fair point that actually that's really difficult to visit people.
To be mindful about
Yeah.
that demographic.
Absolutely.
And sorry, can I move on to my other question? So my other question is, when you were talking about suicide and saying that it's not possible to identify the specific drivers, whilst I understand that, is there any data that actually where our local demographic, we've drilled down so we know what that looks like, the suicide, the occurrence of suicide? So does it reflect the national picture of, you know, male age 40, or have we got a different picture that represents our local demographic? Have we got elderly people that are committing suicide because they're lonely? I don't know. I'm just putting it out there, really.
I don't know the current data, but I am aware that relatively recent data, very significantly middle-aged men is a problem. But it's then after that, it's very, very difficult to say it's from one type of profession or one type of family or one type of social situation. It does vary tremendously, which means in terms of trying to address suicide, you tend not to pick on a particular group and say, I'll put all my intervention on them. It's a much broader approach, excuse me, which is something about, so for example, the council does mental health first aid training. A few years ago, there was some training for all the councillors actually around suicide. It's that type of broad approach where you're trying to cover lots of things so that when individuals come across somebody, they might be able to provide some support. Similarly, I think there is something around how you might influence national broadcasting as well around suicide to make sure the messages that are given out around that. So it's a much broader approach to how you address suicide rather than trying to think what is it in our area, because it tends to be the same approach you need because you can't drill down and say that's what the issue is.
Just would be really interesting to see our local picture. And I'm sure the medical officers and the coroners must have that detail because they report on it via ONS, I guess. So I just wonder if it's, you know,
I can find out. As I say, my most recent knowledge is it was in middle-aged men. The only way that may have changed, and this I'm not sure about, it now might be in middle-aged women as well. I think they were coming up last time I heard, but it's that particular age bracket which is an issue. But I will find out and come back to you.
Brilliant, thank you.
I think obviously there will be quite a lot of discussions about LGR and devolution, and I think, as you said, just to keep things mindful. And I think probably, no doubt, we will be involved in task and finish groups to do with LGA, with town councils. So if we can make reference to that, then we can keep that to the forefront. Thank you. Okay. Oh, sorry, Councillor Placey.
Sorry, yeah, can I ask a question?
Of course you can.
This is out for consultation. It's online. Can I ask if any of you have actually had a look? If not, can you please? And can you spread the news? And any comments like tonight, you know, anything that you want to comment on or you want to add in, or then feel free to do so. Thank you. I don't think so.
Because that might be a really good way of saying, look at this.
Aren't we waiting?
Yeah, we can check that we can raise that with our comms, yeah, because it's definitely on Tendring's website and the link and everything's there. But yeah,
brilliant.
Good point.
Are we going to have a meeting? Isn't there a meeting coming up on that for us to put? Isn't there a meeting to come up for the consultation? I've read it somewhere, or am I seeing things?
There's a meeting with Cabinet and the officers of different departments.
Yeah, would that
in the
be
council? We've got that coming up. Is there what other meeting?
Is that what I'm thinking of?
Sorry.
So there's also, we've got the Health and Wellbeing Board coming up shortly, next week.
Yeah.
We'll certainly be taking it to that. Any other significant meetings where we can take it and speak to our partners, very happy to take it to those as well. And we're also circulating around our partners, such as the Alliance, Essex County Council, voluntary sector, to try and seek their views as well. So trying to get a really broad range of views about, are we aiming on the right things? Is what we should be doing? What else could we be thinking about? Thank you.
Okay, we've got to make a... So it's really recommendations to go to...
To have a go at putting some...
Excellent idea.
Our intention to actually have a look at the finished strategy before it goes back to Cabinet in July. Because at the moment you're still waiting for consultees on this, and maybe it would be good to have a look at the thing before it actually goes back to Cabinet for their final perusal.
Have we got a meeting before that?
You've got your meeting, I think, on the 14th of June. I think so. I think it's just for this committee. I'll just. All right. Which one is it? So there is the opportunity to consider again the opportunity. Your next meeting, you've got quite a busy agenda, so I'm not sure that you'll be able to do that. Obviously, during the lifetime of the policy or the strategy, there's the opportunity for you to review its implementation, and that might be something that you might want to come back to and insert into 25, 26 work
on the work program.
And then, as I say, investigate whether there's been significant progress. My assessment of your responses to what you've heard about the strategy is actually that there wasn't a great deal of opposition to the priorities that were being set out or the practical steps associated with those. And so actually I was going to, picking up on that, suggest that that might be something that you want to put forward by way of a recommendation to Cabinet to endorse those separate priorities. But picking up on again, Councillor Griffiths' suggestion, I think perhaps
give us the opportunity to look at residents' feedback on this, as well as other bodies and stakeholders, because at the moment we have a draft report which is out to consultation. We haven't actually, we obviously, because we're within the consultation process, we haven't been able to see any resident representations on this, which obviously, because they're the people that probably could be most affected by it, as well as other bodies that we're talking to. So it would be good to see whether or not, after consultation with other stakeholders and residents, the nature and the content of the report shifts direction with the other consultations and the other inputs that are put in prior to it going to Cabinet, because I think then would be the time to maybe give Cabinet a sort of an idea of the direction of travel that we as a committee believe this documentation should take.
Chairman, it's entirely up to the committee what it does. I think there is a danger that the committee starts effectively taking on the role of Cabinet, which is there to actually do exactly that work, which is to take on board what consultation responses there are and then come up with a final determination of it. You are a consultee in this process, and you've had the opportunity to comment on it. Obviously, you could have commented further into the process, and you could have benefited from some knowledge about what the consultation was saying. I still think actually that a crucial role around overview and scrutiny is actually how is it being implemented. As it is a good thing to have a set of priorities and defined actions at the outset, but it's also imperative that that those are followed through and actually delivered against, and therefore a crucial role that the committee can play is holding the Cabinet to account in that critical friend process, and seeing how, after 1 year or whatever from the policy being adopted, is it actually delivering the change? Is it actually delivering the practical steps that were held out to you at this stage as being something that the council and its partners were intending to deliver?
So it's more the implementation of it.
I would say there's a role for you there, and I accept what Councillor Griffiths is saying. I just think actually you've got some in your work programme, you've got activity for your next committee meeting. To return to this subject would be difficult. It's not impossible, but also I think actually we shouldn't lose sight of the fact that actually a look back or a look at implementation is something that is vital in this process, and you can play a critical part in that.
So how do the other members feel about it? To use it, to do it as to see how it's implemented?
I think that sounds sensible, if I'm honest. I think because that's what we are here to do. We are, and at that point, I guess we can look at the consultation as part of that, or how that's affected it. I think we also need to be mindful that it is a time of great change. So the strategy is written straddling that time of change. So we need to be mindful of that.
Okay, so we'll go for implementation. Scrutinise the implementation of it. Yeah. Okay.
Chairman, going back to where I started, I think from the discussion that's been held, I think there was no resigning from the position set out in the priorities. So those wider determinants of health, improving well-being and resilience, encouraging a healthier lifestyle, improving long-term condition prevention and management, and suicide prevention. And the practical steps set out in the draft document weren't ones, I think, that the committee objected to. And I would, therefore, there's an opportunity there, if you wanted to send that back to Cabinet with that comment, that you actually support those as principles. Obviously subject to the point that Chris has said, subject to what comes back out from others. But there's an opportunity for you to say that, if that's something that you support.
To mention basically what Chris has said, then go on the implementation of it. We will review the implementation.
Well, you can send it back as part of the consultation that you're actually endorsing what you've received.
And we'll do it as a...
Yeah. And I was going to go on. I think from the discussion this evening, to making representations around or to urge Cabinet and the portfolio holder to make representations around any realignment of the footprint of the ICB, the ICS, and the hospital and alliance footprints, to ensure that the health and well-being of tendering residents isn't inadvertently damaged, and that should also take into account the opportunities for family to visit patients placed elsewhere due to the particular demographic age profile that tendering has. So I think that was something I think that came out of the discussion, to make those representations, to not allow any realignment to occur without the opportunity to challenge why that wouldn't worsen the situation for tendering residents. I know Chris wants to come in on that point.
Sorry.
Would it be possible to add within the recommendations back to Cabinet at this stage that consideration be given to the impact that our internal planning process has within that? Because I think that might be something within the scope of the documentation that might be worth consideration. Now, it might be that because of national planning guidelines, we're not in a position to actually implement any changes. But I think highlighting the fact that the planning policy could have a factor on deprivation and might be worth sort of highlighting for Cabinet or for future reference.
Yes, Chairman. I've written that down as another point to raise, but I think was also just noting that there is going to be that further examination of the suicide data to ascertain what associations do exist with other factors, and to look forward to receiving that data. So I think just laying on record that that's actually something you want to pursue, because actually
with respect, the planning issue isn't just suicide.
No, Chris, I was going to come back to that one, and then so just not losing sight of the fact that commitment was given, that data would be re-examined, and that might influence some of your 2025-26 work programme. But then looking at the evidence around concentrations of populations that exacerbate issues and the role that planning might play in that would also be something that, so I know I took a bit of time to get there, Chris, but I hadn't lost it.
That's an age
I know,
thing,
I know
isn't it?
some people think I do lose it, but I hadn't lost that one. And therefore, you know, the role that planning and planning policy can play in that to either contribute towards that situation or actually, you know, be a weight against those situations arising. So I'd sort of got, and you know, also back to that is looking again at the implementation of the strategy being something to put forward for your 25-26 work programme at this stage. Supporting the priorities and the practical steps, making representations about the ICB, ICS, etc. footprints and not exacerbating problems for local residents. Noting that the suicide data and associations with demographic factors would be coming back to you, and you know, look forward to receiving that information. The impact of evidence around concentrations of populations, exacerbation of issues, and the role that planning can play in that, both positively and negatively, and looking forward to suggesting that by way of the 25-26 work programme to look at the implementation of the strategy. That's 1, 2, 3, 4, 5 recommendations if they are where you're at as a committee.
Couldn't put it better myself.
Thank you.
So can we have a proposition then to recommend those? Yeah, Councillor Griffith, second. Councillor Davidson. All those in favour? Unanimous.
There you go.
Just like that.
There you go.
Okay, so that just leaves us then with the work programme. So you're quite welcome to stay, our esteemed guests, but then again, you're quite welcome to vacate. Oh, okay, yeah, okay. And thanks very much for your participation. I think we had some good lines of debate, and I think we got there in the end.
So, Chairman, if you're happy, I'll just start with a few words. So, the final item on tonight's agenda is the report setting out in relation to the work programme and the various appendices with your 24-25 work programme, the recommendations monitoring Appendix B, and the scrutiny of proposed decisions set out at Appendix C. In addition, you have the update sheet, which updates the position in relation to Appendix B, which is your recommendations monitoring. And so laid out on the table, you've got the fact that Cabinet on the 11th of April, through the portfolio holder for assets and community safety, agreed the recommendations and comments that you made in relation to the community or the crime and disorder reduction strategy. So those have been accepted, and so that was the recommendations from the portfolio holder, and that was actually then the decision of the committee on the 11th of April. So just writing that into that, that's good and positive that you've had that response back from Cabinet.
If you remember, that was the one which came from the press about 99 PCS. Remember, and I think we put it in before we even realised. So, but then again, I think they've had to change that. So I think that's probably ahead of the game then.
Totally, Chairman, always. The other thing I think just to point out is on page 43 and item E is that you as a committee argued for an open day in relation to grant funding, and to report that that has been accepted by Cabinet and being implemented by Cabinet. And again, I think that's something that, again demonstrates the good work of this committee, that you've suggested it and it's been therefore seen as positive and been accepted.
Been impressive.
In relation to the task and finish groups, the both of those task and finish groups, I think, are let's say overdue another meeting, and so it's probably worth recording as part of your decision that you're going to be asking for the arrangements for the meetings to be set up for those next meetings. So there's one on joint working with town and parish councils, and there's one on the youth provision, and we can add into that the earlier discussion that Anne referenced in relation to the good work being done at her youth group.
And I think as well, just going to parish and town councils, I still get a feeling that the OGR are devolution will form a part of that, because I know, us all of us in parish and town councils are earning it. So I'm sure that will come out in those task and finish groups.
And I think another matter that I think is worth actually just recording to try and see if we can make progress with it was the follow-up work following the water quality sort of inquiry. And there was an offer around attending the, I think it's a fuel block company up in Harwich. And I think that's outstanding to try and get that. There was an offer, there was a very kind offer of I think a couple of days, and that didn't materialise. So getting back on that I think would be a good one, plus the attendance at the water treatment work, and down at Bright Sea looking at the chemicals, etc., that are being used to clean the hulls of the boats there and what that does to water quality. So I think there's that was worth recording to try and see if we can't make progress. I think Councillor Davidson wanted to come in at that point.
Yeah.
The work programme, the report identifies that we're at that stage now of starting to invite suggestions for the 25-26 work programme, and we've already seen some suggestions come forward, including around implementation of the health and wellbeing strategy now. I think the chairman's keen that we recognise probably across all the inquiries next year to look at it through the local government reorganisation lens. If there's, it may be that there's a dedicated inquiry around that, but looking at it through, looking at the range of inquiries with through the LGR lens, I think would be important to sort of flag up as we develop that work programme. And one thing that cropped up in discussion last week, I think, was potentially getting a meeting together of scrutiny chairs and vice chairs, potentially, certainly, an initial meeting across maybe Colchester and Braintree, and therefore trying to take forward, either looking at similar issues or looking at complementary issues, just to see if there's the opportunity for greater sharing of information and the opportunity to look more broadly at subjects because of the opportunity of time and effort looking at. So one area, if knife crime were to be one of the subject areas, then you can see that one scrutiny committee might look at some element of it, and another council committee might look at another area. So the opportunity is there, but the first step would be to try and get the chairs and vice chairs together to try and look at what the opportunities are to explore that and then implement it. The other thing I think to say on local government review is just perhaps registering now that whatever the inquiries are that go through the distillation process and up to full council in July is probably to have a sort of break clause almost in there in September or in early October to then take account of what was in the final submission. Because that will be on the 26th of September. And so I think it's wise to, just as a committee, think actually when that submission goes in, an element of certainty will be in your hands at that stage. And so you might want to readjust your 25-26 work programme. Another thing I think just to record would be about approaching the Coastal Community Centre and Dr. Emily Murray around matters concerning where that part of the University of Essex might have evidence, and that might also catch on the point that Chris was raising about planning policy. And I know there's some evidence around HMOs and actions that may be possible to take by authorities such as tendering, and therefore linking in with Dr. Murray might offer something for us to, as we're developing that work programme, so making sure that we link in with that. Finally, I just want to say that your next meeting is intended to look at the issue of dentistry again, so that's a key part of it. The other key element of it at your next meeting will be the preparations for the community governance review for Clacton, Holland and Jaywick, and that's an important part, particularly in the activities for the wider council going into the rest of 25-26. So it's a critical part of that process, and taking the committee through that because of its role in responsibility for elements of that will be an important part of that process.
Yes, there's lots of heavyweight discussions to be had.
But in regard to the community governance review for Clacton, for those of us that are Clacton councillors, are we allowed to sit on the committee when that's discussed, or do we have to declare an interest?
I think there's no specific requirement to declare an interest. I'm always an advocate that if there's any sense with which anybody watching this from outside might think, why are they saying that, to make that comment that you are, one of those Clacton councillors, is always wise, but I don't think it in any way debars you from participation, just as it doesn't debar and shouldn't debar any other councillor not in that area from having a view and expressing that as the process goes through.
For the interest of clarity, will it be possible to get a statement from the monitoring officer for those of us that are Clacton councillors that we could read out just to clarify the situation? Because I think that would be a little bit helpful, because what I might think may be a conflict of interest might differ from the monitoring officer. So to make sure that there's no sort of, shall we say, misunderstandings, if we could have a statement just clarifying the situation prior, that would be helpful.
I think Mersey Island is coast. I was going to say Mersey Island is, I think, coastal.
Oh, it's coastal, yeah. Okay, is that?
It is, if you accept the report.
Yep.
If that could just be
Adopted?
nodding.
Yes.
That's wonderful. I saw I saw the nod.
Have we covered everything?
I think so, yeah.
Okay. The meeting is now closed. Thank you very much, everybody, for your participation.